Hello, and thank you for joining us today. My name is Jennifer Ryan, and I serve as the Executive Vice President at Aurora Health Group. My team and I are proud to be leading the ACEs Aware initiative on behalf of the Office of the California Surgeon General and the Department of Healthcare Services. ACEs Aware is a first-in-the-nation effort to screen children and adults for ACEs in primary care settings, to identify and treat toxic stress, and to provide families with trauma-informed care. The state has set a bold goal for the initiative of reducing the incidence of ACEs and toxic stress by half within one generation. Today we're joined by Dr. Nadine Burke Harris, California's first Surgeon General, who is going to teach us about the science of ACEs and toxic stress. Now, many of you have seen Dr. Burke Harris' TED Talk on this topic. Consider this the 201 version of that presentation. I know you'll find it as informative, as compelling as I have. As a reminder, this presentation qualifies for continuing medical education and maintenance of certification credits. Visit our website at acesaware.org for more information. And now it is my pleasure to introduce to you Dr. Nadine Burke Harris.
Thank you so much, Jen. And thank you to all of you for joining us today for the science of ACEs and toxic stress. And the goal of this webinar is really to ground us all in the scientific foundations for ACE screening and assessment for risk of toxic stress in our patients. So just as a reminder, the 10 original criteria from the Kaiser CDC ACE study include these listed here: physical, emotional, or sexual abuse, physical or emotional neglect, or growing up in a household where a parent experiences mental illness, is incarcerated, where there's parental separation or divorce, where there's intimate partner violence or parental substance dependence. And one of the reasons why ACEs are so important and why they're an important indicator in healthcare is because the ACE data tells us that the more of these a person has experienced, the greater their risk for serious health conditions. And we now understand that the way that this happens is through a biological process called the toxic stress response. So the toxic stress response, and here we're referencing the definition from the National Academies of Sciences, Engineering, and Medicine in their consensus report that was published in 2019. It refers to the prolonged activation of the biological stress response systems that can disrupt the development of brain architecture and other organ systems and increase the risk of stress-related disease and cognitive impairment well into adult years, right? So when we talk about toxic stress, although colloquially you'll hear a lot of people use toxic stress to refer to the stressor, what we know is that in the scientific definition of the toxic stress response really refers to the physiologic stress response, right? What the body does. And I'll talk more about that in a few minutes. So we know that ACEs dramatically increase the risk that an individual will develop a toxic stress response. And at the same time, we understand that ACEs are not the only risk factors for the development of the toxic stress response. That a circumstance, exposure, or condition with documented associations with increased likelihood or susceptibility of development of the toxic stress response, right, is how we would define a risk factor for toxic stress. And we recognize that there's strong evidence to show that other risk factors for toxic stress include poverty, exposure to discrimination, and exposure to the atrocities of war. So one of the things that's really important and a key take home that I want to pull out here is that ACEs are not the only risk factor for toxic stress. But the reason that we call them ACEs, right, is because the data that tells us that an individual with 4 or more ACEs has double the risk for ischemic heart disease, or a child who has 4 or more ACEs has double the risk for asthma, that data is calculated using the traditional ACE criteria, right? And so in order for us to be very precise and rigorous in comparing apples to apples and oranges to oranges, it's important that when we say someone has an ACE score of 4, right, that we're referring to very precisely to the data that gives us that information. And so when we use the ACE terminology in the ACEs Aware initiative, we're referring specifically to the 10 ACE criteria. So those 10 criteria that were included in the ACE study. And then for other risk factors for toxic stress, where we don't have the same odds ratios that have been determined in very, very large population studies yet. And, I know that some of this work is underway, but when we don't have that yet, so we're referring specifically to the, what I call big A, big C, big E, the ACEs from which we have the data from the ACE study. And then we refer to other risk factors where we know that there's evidence of increased risk of developing the toxic stress response as risk factors for toxic stress. So one of the pieces of data that we have, right, that is incredibly important is some of the population data regarding the number of individuals exposed. And what we see is that almost 2/3 of adults in the US have experienced at least one ACE. 15.8% nationally have experienced 4 or more ACEs. This data comes from the most recent CDC data about the prevalence of adverse childhood experiences in the United States. And if you see in this national map here, we see that, ACEs occur in every latitude, every longitude, every socioeconomic and demographic group. And ACEs occur at all income levels, which is why it's important to screen all children and adults for ACEs. But we also know that, particularly in the United States, individuals who are African American, Hispanic or Latino, who are American Indian or Alaskan Native, these populations experience increased prevalence of ACEs. And then we recognize that they may also experience increased risk of other risk factors for toxic stress, such as experiencing discrimination or poverty, because of the history of de facto and de jure segregation and discrimination in the United States. And so it's very important for us to recognize that some of our populations, we see the data on gay, lesbian, transgender, bisexual, queer communities also have an increased prevalence of ACEs, and then also may experience increased risk of toxic stress for reasons of discrimination as well. But what we know from the original ACE data is that there's a dose-response relationship between ACEs and some of the most serious, significant health conditions that are facing our communities today. So in this slide, what we see are the 10 leading causes of death. This data is actually pulled from the 2017 CDC data, so it does not include COVID-19 as a cause of death, but we know that the CDC is in the process of updating their leading causes of death data. But for now, when we look at the 10 leading causes of death, what we see is that ACEs dramatically increases the risk for at least 9 out of 10 of the leading causes of death, right? With an odds ratio of 2, so double the risk for heart disease, 2.3 times the risk of cancer, 2.6 times the risk of accidents or unintentional injury, triple the risk of chronic lower respiratory disease, double the risk of stroke, 11 times the risk of Alzheimer's, 1.4 times the risk of diabetes, 1.7 times the risk of kidney disease, and 37.5 times the risk of suicide attempts. So we see for 9 out of 10 of the leading cause of death, profoundly increased risk of these health conditions. And when we look at what that means, so when we see from that there's a profound healthcare cost, right? But in addition to the toll on people's wellness, right, and well-being, on their health, we also see a profound economic cost. So here in California, when we look at the cost to the state of California from just 8 associated health conditions, including asthma, arthritis, COPD, depression, smoking, cardiovascular disease, heavy drinking, and obesity, we see the annual cost is $112.5 billion per year. That's $1.2 billion over, $1.2 trillion over 10 years, right? Huge economic impact. And what we see is that for child abuse and neglect, so the most, which is part of the ACE criteria, not looking at health conditions, but also looking at the impact on education, criminal justice, welfare, lifetime productivity, we see an additional $19.3 billion annually. So what this tells us is that ACEs affect a lot of people. The impacts are profound in terms of health outcomes, mental health outcomes, overall well-being, and healthcare costs. So that ACEs and toxic stress represent a public health crisis. ACEs are a root cause for some of the most harmful, persistent, and expensive societal and health challenges facing our state and our world today. So when we think about how do we approach tackling this, right? Well, when there's a healthcare challenge, and I will say for myself as a complete science nerd, right? Understanding the biology of adversity helps to give us the tools to know how we can support our patients and really take a smart, both healthcare approach and public health approach to addressing ACEs and toxic stress. So I'll take a minute to dive into the biology of adversity. What we now understand and what has emerged in the several decades since the original publication of the ACE study is that we now understand in much more detail, better than we ever have before, some of the biological mechanisms that undergird this transformation or this progression from early adversity to disease and early death, right? So we understand that the care environment mediates the biological stress response, and that prenatal maternal stress, postnatal caregiver unavailability or absence, or depriving environments, or child abuse or neglect can activate the biological stress response. And that that activation includes changes to our genetics, our epigenetics. And what we see here is that depending on someone's genetic endowment, so whatever their initial genetic code, what their epigenetics that they were born with, right? That influences their susceptibility or resilience to exposure to adversity. But high doses of adversity leads to epigenetic changes. It leads to reprogramming of the stress and immune regulatory systems, and it leads to neurodevelopmental disruption. And all of these ultimately lead to increased risk of cognitive deficits, disease, psychopathology, and social problems. So put another way, we see that early life adversity can be mitigated by protective factors, but it also is influenced by predisposing vulnerability. That can lead to neuroendocrine and immune disruption. And all of that is affected by epigenetic regulation, changes to the way our DNA is read and transcribed as a result of exposure to high doses of adversity. And this is what leads to clinical implications, including endocrine, metabolic, reproductive, neurologic, psychiatric, behavioral, immune, inflammatory, and cardiovascular consequences. But one of the things that's very powerful, right, and it's good to be reminded of, is that the toxic stress response is actually at one end of the spectrum of what physiologic stress responses can be. We characterize the physiologic stress response in terms of the positive stress response, the tolerable stress response, or the toxic stress response. The positive stress response involves brief activations of our stress response, brief elevations in heart rate and blood pressure and hormonal levels, and homeostasis, right? The body's biological balance recovers quickly through our natural coping mechanisms. The tolerable stress response occurs in reaction to a more severe or prolonged stressor. But the tolerable stress response is a time-limited activation of the stress response, and it results in short-term systemic changes. And here is the key. So if there is a take-home point that I want to highlight, it's this. Homeostasis recovers through the buffering effects of caring adults or other interventions, right? I'm going to say that again. Homeostasis recovers through the buffering effect of a caring adult or other interventions, right? And if that care or interventions does not occur, that leads to the development of the toxic stress response, which is a prolonged, long-term sustained change in the biological stress response, which increases the risk for stress-related disease and cognitive impairment. And so when we look at all of the impacts of the toxic stress response, right, we're talking about dysregulation of our sympathetic nervous system, right, our fight or flight response, our stress response, changes to the size and activity of the amygdala, that's our brain's fear response center, inhibition of the prefrontal cortex, the part of the brain that's responsible for executive functioning, toxicity in our hippocampus, which is the part of the brain that's responsible for learning and memory, and changes to the ventral tegmental area and the reward processing system, which is the area of the brain that substances of dependence act on, right? So when you see these changes to the structure and function of the VTA and the reward processing center, leads to increased risk of risky behaviors, increased risk of addiction, right? It's interesting that these risky behaviors are not only increase the risk of later on health problems. For example, if someone ends up smoking as a result of their exposure to high doses of adversity, there's not only the impact on their lungs, right? But what we see is that it's actually the changes in their brain that lead to a greater likelihood of adopting high-risk behaviors. And what that means is that it's not enough just to tell our patients, just say no, right? Or you should quit. But we actually have to address the fact that there may be changes to the reward center of their brain that increases the risk for adopting these high-risk behaviors. Similarly, we see long-term changes to the immune system leading to increased inflammation and inhibition of anti-inflammatory pathways, changes to the gut microbiome. We see changes in our hormonal systems, including growth hormone, thyroid hormone, pubertal hormones, changes in our metabolic hormones that regulate appetite and weight. And we see sustained changes to the way that DNA is read and transcribed, right? So changes to our epigenetic regulation, as well as changes in our telomeres. So accelerated telomere erosion. When your telomeres are eroded too fast, they're the bumpers on the ends of our DNA. They protect our cells from wear and tear. And if our telomeres erode at a more accelerated rate, there's increased risk of diseases like diabetes and cancer. And so now that we understand that biology, that gives us an opportunity to interrupt some of these biological processes. And we're going to talk a little bit about how we do that. So now that we see and understand this neuroendocrine, immune, and genetic regulatory disruption that defines the toxic stress response, one of the things that it's important to understand is that these biological changes can actually be handed down directly from parent to offspring, right? So a parent's ACEs leads to a toxic stress response for that parent, and that leads to changes in stress hormones, neuroendocrine, immune, metabolic dysregulation in the parent. You can see changes in parent behavior, and it can also be impact the social determinants of health by increasing the risk for things like poverty, et cetera. And then we look at how that biologically impacts parents, can affect their ability to conceive. It can actually lead to changes in the stress response system genes that are then handed down to the next generation. And then, of course, it can profoundly impact the parent's health, both physical health and mental health. And that is why in the ACEs Aware initiative, our focus is on screening both children and adults for ACEs as a way of assessing their risk for toxic stress. Because if an adult is identified as being at high risk for toxic stress, we want to make sure that we are employing the stress mitigation strategies that have strong evidence for helping to regulate the stress response as a way of not only treating the adult, right, but also to do prevention for the next generation, right? So this is two-generation work. So when we're talking about California's approach to addressing adverse childhood experiences and toxic stress, we are taking both a clinical approach, but also a public health approach. So now that we understand the science of toxic stress, one of the exciting things is that we also have a lot of science about how to interrupt the toxic stress response, right? And this is critical for helping us break the intergenerational cycle of ACEs and toxic stress and promote an intergenerational cycle of health. The number one thing that we know, and this was something that was a key standout point in the National Academies of Sciences, Engineering, and Medicine consensus report, is that early intervention is key for improving brain, immune, hormonal, and genetic regulatory control of development. We know that treatment of toxic stress in adults may prevent transmission of the neuroendocrine, immune, metabolic, and genetic regulatory disruptions in their offspring, right? So taking that two-generation approach, we want to do screening, early detection, and evidence-based intervention, not only in children, but also in adults, to both improve health outcomes and then also prevent the intergenerational transmission. Just as we would treat HIV in mom, if we have a pregnant patient, we put her on antiretrovirals so that she does not transmit that HIV to her offspring. And we've seen this profound decline in children born HIV positive. Similarly, identifying and treating adults allows us to be able to intervene against that vertical transmission of toxic stress. And how do we do that? Well, it starts with screening. And when we look at the screening algorithm, so the ACEs Aware initiative convened a group of clinical experts, our clinical advisory committee, who really brought together all of the latest science and synthesized it into a clinical algorithm for assessment of ACEs and toxic stress. And I want to start by highlighting that an ACE screen is not just the form that a patient fills out with the number of ACEs that they've experienced. In fact, a complete ACE screen involves a triad of the ACE score, the assessment of ACE-associated health conditions, or clinical signs and symptoms of a toxic stress response, and as well protective factors, right? These three factors is what constitutes a complete ACE screen. So an ACE screen is not just the score alone, But when we look at the ACE score, the way that the algorithm works and the way that we interpret it is if the score is 0, we understand the patient is at low risk, not no risk, right? Because we know there are other risk factors for toxic stress as well, but we say low risk. For those, and this is for pediatrics, with an ACE score of 1 to 3, we then go through that assessment of ACE-associated health conditions. And those without ACE-associated health conditions in the pediatric patients are considered to be at intermediate risk. And for those patients, we want to provide education and anticipatory guidance on ACEs and toxic stress and buffering factors. But if a pediatric patient does have ACE-associated health conditions, right? Or if they have an ACE score of 4 or more, with or without ACE-associated health conditions, they're considered to be at high risk. And the reason for that is that even though a child may have an ACE score of 1 or 2, if they're demonstrating that they have asthma, for example, because we know that a child with 4 more ACEs has double the risk for asthma, right? And we know that for every ACE a child has, there is a cumulative increased risk for asthma. So we recognize that asthma as an ACE-associated health condition would put that child in the high-risk zone. And the reason for that is because if a child is showing symptomatology, then it helps us to understand that if they are showing symptomatology, their body may already be experiencing the impacts of a toxic stress response or prolonged activation of the stress response. So we have a lower threshold in children for considering a child to be high risk and intervening. And with that intervention, we provide education about toxic stress, its likely role in the patient's health condition, and the importance of buffering. And we assess for protective factors. So if a child has any ACEs, we assess for protective factors and jointly formulate a treatment plan, including links to supportive services and interventions as appropriate, right? So this is how we use the triad way of assessing for risk of toxic stress, right? And we categorize patients as being at low risk, intermediate risk, or high risk of having a toxic stress physiology. And so I've talked about the ACE-associated health conditions. On the ACEs Aware website, you can download the list of ACE-associated health conditions. This is for the pediatric health conditions. And it also has the odds ratios based on an ACE score of 4 or more. So for example, we can look and see that for individuals who have an ACE score of 2 or more, the odds of them having later menarche is 2.3, right? For an individual with an ACE score of 4 or more, the odds of them having school absenteeism is 7.2. So these are all considered ACE-associated health conditions. For an individual with an ACE score of 4 or more, the odds of them having a teen pregnancy is 4.2. So again, understanding these ACE-associated health conditions, understanding that our patients who are at high risk for having a toxic stress physiology are at greater risk of having these health conditions. And then in assessing for protective factors, right, we recognize that protective factors can be intrinsic factors. So some of these protective factors can be neurologic, endocrine, metabolic, immune, genetic, or epigenetic factors. And what we recognize there is that someone's family history, someone's genetic endowment is going to be a protective factor for them, right? But other factors that are also protective factors that we can assess for are things like curiosity and learning, ability to pay attention, ability to regulate emotions, as well as extrinsic factors like buffering relationships, supportive environments, and community resources, right? So assessing for protective and buffering factors is the third part of the triad of ACE screening, and it's really, it's critically important. So I just walked through the pediatric algorithm for assessing risk of toxic stress. Similarly, there is an adult algorithm that you can find on the ACEs Aware website. You'll notice that for adults, the algorithm is slightly different, which is that for adults, if the score is 0 to 3, and then when we assess for associated health conditions, they have no associated health conditions, that's considered low risk. For adults, if they have a score of 1 to 3 and they do have associated health conditions, that's considered intermediate risk. And for those with a score of 4 or more, with or without associated health conditions, is considered high risk. And for those patients at intermediate and high risk, we again do the same thing that we do in pediatrics, provide education about toxic stress, its likely role in the patient's health condition, and resilience, right? And we assess for those protective factors, and we jointly follow up the treatment plan. And one of the key pieces is that we provide support, we provide links to support services and treatment as appropriate. And you'll see here, we have the list of the ACE-associated health conditions in adult, ranging from cardiovascular disease, tachycardia, stroke, COPD, asthma, diabetes, obesity, cancer, all the way to sleep disturbance, depression, suicidal ideation, anxiety, substance use, alcohol use. So you can see the odds ratios there for individuals who have an ACE score of 4 or more. So when we think about our clinical response, so how do we take this information and put it together? Well, step 1 of a clinical response to ACEs and toxic stress, right, to identifying that a patient has experienced ACEs and is at intermediate or high risk of having a toxic stress response, is to apply the principles of trauma-informed care, including establishing trust, safety, and collaborative decision-making. Step 2, and this is really the key part that primary care providers have an important role in doing and supporting, is supplementing usual care for ACE-associated health conditions, right? And whether that's asthma or chronic lung disease. Supplementing that usual care by providing patient education on toxic stress, right? And offering strategies to help regulate the stress response. And I'll walk through some of those evidence-based strategies in just a moment. It also includes, as I mentioned, validating existing strengths and protective factors, because you want to build those into your treatment plan. One of the things that I've done in my clinical practice is to say, okay, here are the evidence-based strategies that help to regulate the amount of stress hormones that your body makes. How are you doing on these? On a scale of 1 to 10, how are you doing on exercise? How are you doing on mindfulness? Where are the places do you think you want to, should we make a plan to augment or supplement? And then at our next follow-up visit, I'll see how you're doing and see what is the progress against the health condition that we're trying to manage, right? So this is fairly simple and straightforward. Of course, referrals to patient resources and interventions, whether it's education materials, social work, school agencies, care coordination, patient navigation, community health workers, or mental health if necessary, right? But I want to emphasize that not every patient who is at high risk of having a toxic stress response requires a mental health referral, right? So that's really based on whether or not they have mental health symptomatology that that requires a mental health referral. And then follow up as necessary, again, using that presenting ACE-associated health condition as an indicator of treatment progress. So when we look at the evidence for helping to regulate the biological stress response, we see that, for example, in children, MRI studies have found that institutionalized children who were randomized into high-quality nurturant caregiving showed normalization of the developmental trajectory of the white matter structures of their brains, right? So we know that safe, stable, and nurturing relationships can actually heal some of the neurodevelopmental consequences of toxic stress. Similarly, responsive caregiving improves cortisol reactivity in children, and things like time in nature reduce the activation of the sympathetic nervous system, that fight or flight system, And it increases parasympathetic activity, right? Which counteracts, that's our resting and digesting system that counteracts the fight or flight stress response. Things like meditation are associated with regulating the immune system, with decreasing inflammatory mediators like interferon gamma and natural killer cell production of interleukin 10, as well as increased T cell production of IL-4, which is an anti-inflammatory interleukin. Healthy sleep helps to reduce the infection risk and improves the vaccination response by improving the function of our immune system. And moderate exercise also helps to regulate our immune system and decreases infection risk. So some of these evidence-based strategies that we know act directly on regulating the stress response. And we see this evidence by, clinical evidence of decreasing stress hormones, decreasing inflammation, enhancing neuroplasticity, and improving neurologic function, right, are some of the strategies that we can use to intervene to help a patient regulate their stress response and decrease their risk of ACE-associated health conditions and stress-related disease and cognitive impairment. And so when we boil a lot of this literature down, we looked at, tens of thousands, over 20,000 research articles. What we see is that sleep, exercise, nutrition, mindfulness, mental health interventions like psychology or seeing a therapist or psychiatry, supportive relationships, and experiencing nature all help to reduce stress hormones, reduce inflammation, enhance neuroplasticity, and regulate the biological stress response. And so these are the interventions that we can educate our patients and say, because of what you've experienced, your body may be releasing more stress hormones than it should. And these interventions can actually help to regulate your stress response. So in addition to the, X, Y, and Z usual care for the health condition, right? So in addition to the albuterol and the inhaled steroid, I'm going to also recommend these interventions to help to address the toxic stress component of your ACE-associated health condition. And together, we're going to see how you're doing and see if whether or not these things are helpful. And we're going to start by praising you for what you're already doing great. So, and helping you to notice what things help and what things make it more challenging. So now we understand what this response looks like in clinic. What's the next step? Well, the first next step is taking the ACEs Aware provider training, where we have a lot more information on ACEs and toxic stress, trauma-informed care, best practices in the clinical setting. So get trained. And if you're a Medicaid provider in California, please complete the attestation so that you can qualify for reimbursement for screening for ACEs. And please join our ACEs Aware clinician directory so that your patients can find you. Anyone who is looking to identify an ACEs Aware clinician we have a clinician directory to allow, that's online, to allow patients or folks to identify an ACEs Aware provider. And the next step is to join a trauma-informed network of care. Here in California, we are establishing trauma-informed networks of care. We have resources that we've deployed in many counties throughout the state. And what we mean by a trauma-informed network of care, it really starts with a recognition that when we're talking about addressing ACEs and toxic stress, there's no way, right? We're not going to solve it all in the exam room. That some of the interventions that we do are going to be in the healthcare provider's office, and some of them are going to be in the community. And so a trauma-informed network of care is a group of interdisciplinary health, education, human service professionals, community members, and organizations. They support individuals and families by providing access to the evidence-based buffering resources and supports, and they help prevent, treat, and heal the harmful consequences of toxic stress. So who is in a trauma-informed network of care? Well, they include primary care providers, behavioral health providers, schools and educational professionals, early intervention services, social service programs, local county and government programs, community-based organizations, tribal organizations, our legal and justice system, a digital health and technology platform to connect and coordinate folks, and our provider networks and managed care plans are all essential components of a trauma-informed network of care. And for more information on trauma-informed networks of care, please check out our ACEs Aware website, where we have our roadmap for creating and building a trauma-informed network of care that anyone can download and get that information. And one of the things that you'll see in the roadmap is how to work towards network of care milestones. And that includes building and committing to cross-sector partnerships to establish a formal leadership and accountability structure in order for us to make sure that patients have the opportunity to heal. We have to be clear about who's doing what and how they're accountable, right? And so building those structures is part of a network of care. Understanding and documenting available resources such as healthcare, community-based, and social service resources, establishing referral and response workflows across sectors, and holding each other accountable for follow-up, leveraging technology, as I mentioned, and evaluating, refining, and improve the network of care activities. Because we know we're not going to get it perfectly right out the gate, right? But committing to that continual improvement is so important. And then finally, we understand that while the network of care is essential, right, that no single sector or category of prevention is sufficient alone. And when we're taking a public health approach to addressing ACEs and toxic stress, it requires what we call primary, secondary, and tertiary prevention. Primary prevention is preventing ACEs and toxic stress from happening in the first place. Secondary prevention is early detection, so that is screening to enable early detection so that we can intervene earlier when we have a better opportunity to have better outcomes. And then tertiary prevention, which is evidence-based intervention for treatment, right? We need all three. And we need primary, secondary, and tertiary prevention, not just in the healthcare system, but in all of our systems. And that is really what a public health approach is about. And that's healthcare, public health, social services, early childhood, education, justice, all of the above. I would say housing, you name it, it should be part of a public health response to ACEs and toxic stress. Again, we wouldn't leave you without resources. So a real roadmap to understand how we do that can be found in the California Surgeon General's report on adverse childhood experiences, toxic stress, and health, called Roadmap for Resilience. It's available on the Office of the Surgeon General website, and it really walks through for each of the sectors that I mentioned previously, how we can do primary, secondary, and tertiary prevention of ACEs and toxic stress. And as we look at this public health approach, a key component for a public health approach is public awareness. It's step one. It's critically important. And that's why I'm very pleased to announce the public education campaign, resources, information for the general public to understand what are ACEs. What does an ACE score mean? What is the implication? Why would my provider even ask me about these questions? All of this is available at a new website, a new initiative called numberstory.org. And that is to help folks understand the story of their number, right? Because we know that no 2 is the same as another 2, no 4 is the same as another 4. It's not so much about exactly what your number is. It's helpful to understanding your number can be important to understanding your own story. But the powerful thing about the Number Story Initiative is that it makes it clear that each individual has the opportunity to write their own story, to determine how their story is going to turn out, and hopefully understanding how ACEs may be playing a role, ACEs and toxic stress may be affecting their story, is critically important. And here in California, we have launched an initiative at the same time. These are partnership initiatives called Let's Make Our State of Care ACEs Aware. And that's really targeted at our healthcare providers so that our healthcare providers can really be part of helping patients access information about ACEs and toxic stress, be a resource to their patients, and get access to healing interventions. And so we're very excited about the State of Care initiative, because we want the state of care in California to be ACEs aware, to be trauma informed, and to be toxic stress responsive. Looking to the future, we are incredibly pleased that this work really serves as the foundation of a much larger effort here in California. Governor Newsom has proposed in the budget $4 billion for a comprehensive child to young adult behavioral health initiative. And that includes everything from public education, trauma-informed care training for educators, increased school mental and behavioral health providers, investments in our behavioral health workforce, investments in crisis and acute beds. So really the whole spectrum, from prevention and public awareness to increased resources for those who need inpatient services. And all of this is really about taking a public health approach to understanding how early adversity, ACEs, toxic stress can ultimately lead to increased risk of health and mental and behavioral health conditions, and really taking a public health approach to prevention, early detection, and evidence-based intervention. So thank you so much for your time and attention, and I look forward to answering any questions.
Thank you so much, Dr. Burke Harris, for that informative presentation. We have just a bit of time for questions before we close. First, not surprisingly, I need to ask you about the COVID-19 pandemic. As we know, the data is starting to reveal the far-reaching impact that the pandemic has had on our physical and mental health as a nation. What are your thoughts about how we can best address this together?
That's a great question, and it's something that I talk about quite a bit in the Surgeon General's report, the Roadmap for Resilience report, because one of the things that we recognize is that the pandemic has not only been a huge stressor, but it's also cut us off from those sources of buffering caregiving relationships that we know are the difference between the tolerable stress response and the toxic stress response. So we can anticipate, just looking at the biology, that there's a likelihood of significantly increased prevalence of that prolonged activation of the physiologic stress response, right? The toxic stress response. And what that means is that it really requires a public health approach to addressing these challenges and to healing from the pandemic. And so that public health approach, again, I talk about it a lot in the Roadmap for Resilience report, but it requires self-care for educators, right? And one of the things that is critically important in order for any of us to do this work, to be responsive to ACEs and toxic stress and the stress of the pandemic, we have to be practicing the self-care, right? We need these tools for self-care. And that's why training on vicarious trauma, secondary traumatization, and really how to prepare yourself to be able to do this work and to do this healing work is really important. How we can practice those self-care strategies, I think, is critically important. And then we really need to be looking across every sector and thinking about how do we work together to address some of these challenges and really take this public health approach, because the scale of the challenge, particularly coming out of the pandemic, is enormous. And so if we think that we're going to do this in this very fragmented system, right, I think it's clear that that just doesn't make sense anymore. And so I think we have truly an unprecedented opportunity now coming out of the pandemic. I think there's no one who doesn't recognize how important it is for us to address the impact of stress on our physical and mental health. And so I see the pandemic and this moment as we're emerging from the pandemic as a tremendous opportunity for healing, and particularly at the policy level. So I will say that it's a time for us to really hold our elected officials to account, to implementing some truly healing and restorative policies.
And last question. Dr. Burke Harris, the events of the past year have brought issues around health equity into even sharper focus. Some people are saying that exposure to racism and discrimination should be considered ACEs. What are your thoughts on this?
Yeah, I think that's a great question. And when people say that, I typically respond by asking, what do you mean by that? And why do you think it should be considered an ACE, right? Because when we look at the data and we look at, for example, when we look at the global meta-analysis that was published looking at ACEs and health outcomes from more than 17 different countries around the world. And in order to, one of the things I want to say is that in order to be able to implement an initiative at a government level like ACEs Aware, we have to base our information on these very, very large studies that can stand up to very high levels of scientific scrutiny, right? So we have to base this, the strength of the evidence that we have is the strength of the evidence that we have provides the foundation for us to be able to implement policy and spend public dollars on these initiatives. And so for that reason, when we say exposure to racism should be included as an ACE, I think what people are intending is that it should be identified as a risk factor for toxic stress, because that's what we're trying to treat, right? Because it wasn't originally included as one of the ACE criteria, then we simply just don't have the information about the relative risk of ischemic heart disease or Alzheimer's or anything else. And so we can't impute those odds ratios to the impact of racism because we simply don't have that same information. But I think the point is, when I hear that, should exposure to racism be treated like an ACE? And my answer to that is yes, because they're the same thing. And this is what I mean by that. ACEs are risk factors for toxic stress. And we already know that exposure to discrimination is also a risk factor for toxic stress. So we can see from the data that exposure to discrimination increases the risk for neuroendocrine, immune, and genetic regulatory disruption. We see that, right? And so I think typically that when people say, oh, well, isn't discrimination an ACE? I think what they mean is, shouldn't it receive the same treatment? And my answer to that is absolutely, because we know that it is a risk factor for toxic stress, and toxic stress is what we're trying to treat. We're not treating the ACEs, they happened in the past. We are treating the toxic stress physiology. And this is one of the things that, we had a series on this as part of our webinars, as part of ACEs Aware, is understanding exposure to racism and discrimination as a risk factor for toxic stress, because the same interventions to regulate the toxic stress response that we apply for individuals who have who are found to be at high risk for toxic stress based on their ACE screen, right? Their ACE score, their symptomatology, and their protective factors. Those are the same interventions that we want to apply when addressing racism as a risk factor for toxic stress. So we want to make sure that individuals have safe, stable, and nurturing relationships and environments, right? That's key. And addressing racism is a fundamental part of ensuring that that everyone has access to safe, stable, nurturing relationships and environments. We want to make sure that folks have safe places to play. And so the disinvestments that we have seen in certain communities because of histories of redlining, because of histories of discriminatory practices, right? Addressing those factors to ensure that there's adequate green space, that there's investment in community factors for resilience building. All of these are part of treating and addressing toxic stress, which is key. But it doesn't mean that racism is an ACE. It just means that it's similar to ACEs. It is a risk factor for toxic stress.
And that concludes our presentation for today. Thank you so much for taking the time to join us and learn about these important issues. As a reminder, you can download the recording of this session on our website at acesaware.org, and you can also submit certification for MOC and CME credits. Have a good rest of your day. Thank you.